Good afternoon, everyone. Welcome to our Satellite Symposium. Boa tarde a todos. I would like to introduce Dr. Ming Tian, who is a professor of a postgraduate department of anesthesiology at the Beijing French Hospital, which is associated with the Capital Medical University. Dr. Ming is also the co-president of the International Airway Management Society, which the other co-president is in the US. He's been a leader of the Airway Management Group in the Chinese Society of Anesthesiology. He's also been the president of the Society for Innovation and Promotion for Anesthesiology, as well as the Beijing Municipal Center for Quality Assurance and Improvement in Anesthesia. So welcome, everybody. Thank you for being here. And here's Dr. Ming.
Thanks for Ms. Lisa's introduction. And hello, everyone, ladies and gentlemen. You are welcome. And sorry. Okay. My name is Tian Ming, come from Beijing, China. My mother tongue is Chinese, but I try use English to give this topic, and a little bit slowly. And 2004 in Paris, I'm the negotiator for Chinese Society of Anesthesiology, joined in WFSA. And I'm also the former leader of CSA Airway Management Group. And we organized teams to attending 2 times World Airway Management meetings. And this is intubating supraglottic airway device, ISAD. And I'm the inventor of SAD Blockbuster. And here today we talk about 5 items. The first is changes in morbid obesity. And second is difficult airway assessment and classification. And then we talk about how to preventing hypoxemia during induction. And then the advantage of intubating SAD. The last one is application of SAD Blockbuster. And now in China, we have the highest number of obese people in the world. So every day in the operating room, we met this kind of patient. Today we focus on the obesity class 3, morbid obesity, that BMI is over 40. And why we call the morbid obesity? Because this kind of cases coexisting disease like type 2 diabetes, heart disease, severe sleep apnea, hypertension, certain cancers, and some joint problems. With these problems, the people's reduced their life expectancies. So now the sleeve gastrectomy is very often. In my hospital, every year we do about 300 to 500 cases, like these people, very big body. And these people have respiratory physiological changes, especially the fat accumulation in the upper airway, we call the OSAS, and also in the chest wall and abdomen, rise the diaphragm. During the supine position, the FRC is decreased significantly, and VQ ratio is decreased. Lung clearance decreased. Airway resistance increased. So this kind of people, different airway is increased. And the important things, their tolerance to hypoxia is lower. And before anesthesia, we should be give the assessment about difficult airway according to difficult mask ventilation, difficult tracheal intubation. This is like other people's. We focus on the BMI, age, jaw protruding, and lack of teeth, snoring, bird, blood party class, and so on. For this DTI, we also should check the BMI and Malin-Patty class and mass opening and thyromental distance. And except this, we should know the METs and also OSA. For METs, we know the 12 levels, but WHO recommended over than 150 minutes per week of moderate intensity. That is okay. So at least let the people, the MET is over 4. And then we use the stop-bound test to screen OSA. The snore, we have a question, ask patient or ask their relatives, do you snore loudly? And do you often feel tired, especially during daytime, sleeping during daytime, and so on. And also we should record the BMI, age, neck size, gender. And after assessment, we give the classification. The first is the identified difficult airway, and second is suspicious difficult airway. A lot of obese patients belong to this. And the last one is the physiological difficult airway, especially morbid obese. This is an example for identified DA, the Pierre-Robin syndrome, and the burn scar for face and mouth. This kind of case, we should give a wake intubation. And then the suspected DA. For the obese cases, there are increased incidence about 10 to 20 times. But why is it suspected? Most obese patients do not have difficult airway, but easy to hypoxemia. For physiological DA, like COPD, respiratory failure, chronic heart rate failure, severe anemia, morbid obese. Today we talk morbid obese, and even infants. This kind of people, their airway is okay, but cannot tolerate apnea and hypoxia. How to preventing hypoxia, hypoxemia during induction. So the important idea is how to extend safe apnea time, SAT. This is the time from apnea until the patient's blood oxygen saturation drops to 90%. For the normal people, roughly we have just 1 minute. But the methods, how to extend in SAT, the methods is pre-oxygenation and also plus apneic oxygenation. So for the obese patients, the pre-oxygenation is mandatory. And how to give the good pre-oxygenation? We have 3 elements. The important thing is maintaining FRC. So the position is very important. And also another tool is easy to get in. Is FiO2. We give 100% oxygen and give enough time, more than 5 minutes. But the position is important. Back, neck, and head elevate. We often use the rammed and reverse translambar position. The translambar position and reverse translambar position and ramped position, we should get the jaw is over 60 degree, 90 degree from chest. This is 90 degree here from chest. And then the face is higher than chest. The face, the level is higher than chest. And the ear to sternal angle in the same horizontal plane. This ear to the sternal angle is in the same level. So this kind of position can increase FRC, improve airway, and facilitate intubation. And how to give the induction and intubation for the obesity cases. We can use rapid induction, and we also can use the awake induction. But today, we focus on the 2-step slow induction for suspected DA, especially for morbid obesity. The 2-step induction intubation with ISAT, which is more effective for morbid obesity patients, as maintaining spontaneous breathing or transitional device for intubation. We do a lot of research, clinical research about this. And now we introduce the advantage of ISAT. I invented the ISAT and tuber in 2012. And this is a SAT blockbuster. It's one of ISAT. And I will introduce the structure design and a special new technique for intubation. We called bronchoscopy monitored intubation. And this is a SAT blockbuster and its tube. And the tube is centered and half-bullet shaped tip, long and soft. It's easy to intubation and very small damage. And for the design, I get the idea, but now we got the idea. We want easily intubation like fast track, like this very famous intubation RMA. And I want the high seal pressure like Procedure. And also easy inserting like Supreme. So this is a 3D structure. And this wing curve and large lemon and without slope and very easy intubation. So this article published 2023. This is compared. This is a Blockbuster. This is a fast track, but they called IRMA. This is a Blockbuster, and they get the conclusion. Compared to the IRMA, the Blockbuster is more convenient, effective, simple, and faster intubation device. And then I got a multi-center research about a large number, and then compared the Blockbuster compared with Supreme. and we get the conclusion. That is, SAD blockbuster is superior to the RMA Supreme in terms of OLP and success rate at the first attempt, and fiber optic view of positioning. That is, lemon is very large, so easy use the fiber optic. And recently, we have another two research. We use the fiber scoop monitored intubation. That is different from the guided intubation. So when the SAD is in the position, we can check. We use fiber scoop or video. We can see the position is okay or not. If position is okay, we can give after ventilation 2 or 3 times. We can give the intubation. And this intubation we call the monitored intubation because the length of the pharyngeal scoop, fiber scoop, the length is behind the tip of the tube. We can see all the way the intubation. Sorry. This is the tip. We can see all the way. So this is not blind intubation. This is monitored. If you, with some resistance, you can see some problem you can deal with. And then it's easy because you don't need to go through and to find the position. And this is very easy because why we can do like this? Because the tube and the SAD outlet are very close to the glottic diuration. So the last one, we introduced the application of Blockbuster SAD in the obesity cases. The 2-stop slow induction. The patient can tolerate SAD incision under light anesthesia and keep spontaneous breathing. With this device, we can easily intubation. We use fiber scope monitored intubation. And how to give the induction and with the spontaneous breathing? We do the research. Feasibility study of jaw thrust as an indicator, assessing adequate depths of anesthesia for incision of SAD in the morbid obese cases. And conclusion is the jaw thrust test. We a little bit give the jaw thrust test. It's a reliable indicator. Determine adequate anesthesia depths of sevoflurane inhalation induction for successful incision of SAD in spontaneously breathing morbidly obese patients. So for this kind of induction with the jaw thrust test is useful. And we can see this video. And this piece is a high. And we can see the carbon dioxide waves, the patient spontaneously breathing. Till the piece down to nearly 40, even below 40. And the carbon dioxide still can see. And patients still keep the spontaneous breathing, but the breathing is a little bit weak. And then we give, you can see the 40. Then we give the test, jaw thrust test. It's okay, no resistance. Then we give insertion, the SAD. Afterwards, we do another research. For the sevoflurane, we plus DEX. The DEX reduce sevoflurane EC50, and that makes the patient keep the spontaneous breathing. So now we introduce the slow induction two-stage. The first for ISAD insertion, we give the rammed position, pre-oxygenation, and light anesthesia. No muscle relaxants. Keep patient spontaneously breathing. After jaw thrust test, insertion of ISAD. And then we give ventilation test. Ventilation is okay. We use video bronchoscope to check the position. The position is okay. Now the airway is in our hands. And then we go to the second stage, give the intubation versus ISAD in place. If the CL is good, we deepen the analgesia, and injection muscle relaxant, intubation through the ISAD by video bronchoscopy. We can use, if you use the you can use the Blockbuster ISAD. You can use the monitored intubation. If you use another ISAD, you can use the guided intubation. If the CI is not good, we can adjust the ISAD, keeping spontaneous breathing, and or wake up the patient, change other intubation technique. And we can see this video, the position, and give the sevoflurane induction. Use muscle airway. And then we give the insertion of the SAD. We can see now the patient still spontaneously breathing. You can see here, still breathing, even weak. After that, we give the muscle relaxant and then give the intubation. So the ISAD can ventilate and also can intubate. So do not stop breathing before airway controlled. That is for the morbid obesity case is very important. Never put the patient into hypoxic situation, and also never corner ourselves, anesthesiologists. This is a little summary about induction for this kind of people. If identified DA, we must be choose awake sedation, topic anesthesia, makes the patient cooperation. And if, like obese cases, suspicious GA, we must be give light GA, two-step induction we introduced, and keeping spontaneous breathing. And during this time, we must be reassessment by video laryngoscope or ISAD. If the position is bad, we go back, wake up the patient, or we think about another technique. If the position is okay, we can deepen anesthesia, like rapid induction. Anesthesia monitor and management. The monitor, we focus on the respiratory function. For the blood gas, for continuously intra-artery BP, for carbon dioxide, and so on. And management, we should use the ideal body weight, IBW. IBW is equal height to minus 105. And important things, during the maintaining respiratory function, we should be increase the FRC. we use the IPPV plus people or CPAP to prevention the atelectasis. And during PACU and ICU, PACU, we should keep the rampant position, still with the back up. How many degrees? For 20 to 40 degrees. The patient is fully conscious. And then, if you want to give extubation, you must give the same personnel and equipment as intubation. And then, the SAD or LMA is an essential transitional tool and can be used to observe until full consciousness, because a lot of cases with the OSAS. And in ICU, we should give a long time to monitor, pay attention to hypoxemia over 24 hours. And then we should give the non-invasive positive pressure ventilation, keep the patient respiratory okay. Summary for anesthesia in obese patients. The first is pre-anesthetic assessment. Focus on airway and respiratory compensatory capacity. And then pre-oxygenation is mandatory. The position is rammed and reverse Trent-Lambert position. And today we focus on two-step slow induction intubation technique is preferred for morbid obesity patient. ISAT is an essential airway transitional device. So we should remember to not stop breathing before airway controlled. Thank you for your attention. And we have a full questionnaire, and if you are interested, and you can to copy this one. And any question? Okay. We can sit here.
Yes, good afternoon. So we have a few minutes left that we left for questions and answers. We can take questions in probably every language right now. So there are microphones in the hallway. And also there's this questionnaire if you kindly want to send it over. Dr. Ming has a lot of experience with developing products and solutions for safety on airway management, so it will be a pleasure to answer any questions you might have.
Okay.
Dr. Ming, thank you very much for your informative talk. It's airway management and obesity seem to be an increasing challenge for us as anesthesiologists. Can you elaborate more on your two-step induction? I assume that inhalational induction would be long, prolonged, and more difficult. And I was wondering if you're using a low dose of propofol, or you mentioned dextamidate for maintenance under light anesthesia, but what are your techniques for the two-step induction?
So your question is about the inhalation induction is a little bit of a long time, you mean? You often use propofol and remifentanil, is right?
Yeah.
So if the patient is a very, very big, large body, so I choose from the safety, idea. I choose to keep the spontaneous breathing. But I introduce this way is a very safety. But take time is acceptable, not too long. Maybe with 10 minutes, I think within 10 minutes, like that. But it's safety. But you can use your methods if you keep without muscle relaxant. But the remifentanil is not so okay, but preferable with a topical, if you can do that. After video laryngoscope check is, we can see the CL is okay. You can do that.
Thank you.
We have a question on the right. Yes. Yeah.
Thank you for your presentation, Mr. Tuoren. I have a question. Actually, I have two questions. First question is, so during your light sedation, light anesthesia, do you have any concern about awareness? And secondly, because you have light anesthesia, do you have any concern about laryngospasm?
Okay, that's a good question. Yeah, this is the first question. Okay, so that's why we do the jaw thrust test, but we use the strong, not so light, strong to take this test. If you use strong test, no resistance is okay, according to my research, but not too large numbers.
Thank you.
But before it's too light, maybe the patient gives the resistance. Yeah.
And what about laryngospasm? I mean, having an obese patient with spontaneous breathing without muscle relaxant, do you have any concerns about developing laryngospasm?
Sorry.
The spasm if you have, because they're not a muscle relaxant, if you have concerns about them developing spasms.
Oh, yeah. But we haven't met this kind of things. But that is concern. Yeah. Like a first question, if we give light anesthesia, but not too light, that is okay, because the SAD is not touch the esophagus.
Thank you.
Are we good?
Susilo Chandra from Indonesia. I have two questions. Usually, how long you have to wait your induction with C4 until you can insert the SAD, and then why not from the beginning you combine C4 with dexmedetomidine and also lidocaine, since we know lidocaine can prevent the patient from coughing or bucking. Thank you.
You want me to go back to the first question?
Maybe Professor Zhu help us.
Do you want to bring the mic? Yes.
I can try. I'm just like you guys, it's just attending the ESA here. But Dr. Tuoren is a friend of mine, so I'm here to support him. And I actually talked to him about the same question, sort of, yeah. I think that he said if you do a really heavy jaw thrust and the patient doesn't respond, and you know that the muscles relaxed, and that won't be too light. And so that will also avoid awareness and also the laryngospasm, so that's the time you do. And of course that I think that sometimes they do use lidocaine to spray. I mean, that's absolutely a way, but I don't know if Dr. Tuoren actually tested this, yeah, to spray the lidocaine. 他说你是不是考虑用那个利多卡因这个喷雾剂打到气道里面，然后来防止病人的反应。 Yeah, of course, yeah. I just don't know. Of course, yeah. I just don't know if he tested, yeah.
Does you mean why I don't use the lidocaine to give the optic?
Whether you guys use or not, yeah.
Have you used
He feels that that's a good way to do
Yeah.
it.
We haven't used that one because the base is near the 40. It's very high, very deep, very deep. Yeah. You can use. Yeah, that's okay. You can use.
Okay. Do we have any more questions?
Use topic is good.
Are we good? We're good?
My anecdotal question, if unluckily, when you try to jaw thrust the patient and then the patient is coughing, what will you do?
So before we met this kind of things, if too light, the patient cannot insert the SAD, and also patient move and coffee like that. So we still give the mask to take a long time to give the inhalation. Yeah.
Thank you.
Do we have any more questions? Yes, in the back.
Do you have any experience, the same technique you described, not using sevoflurane in morbidly obese patient, but using high flow oxygen, 60 liters per minute with high flow cannulas and propofol rather than sevoflurane?
Your question is, do I have experience about another method to give the two steps induction? But I haven't used the high flow nasal oxygenation. But more than half cases, we don't use these inhalated methods. But for the morbidity cases, if the body's largest patient, we choose these methods because that is safety. If the patients, they are OSAS, not so severe, and we often use the video laryngoscope. And we use reassessment during the induction. We use reassessment. We can. This is worked.
Let me know if you have used propofol instead of cyclophosphamide.
Yes, propofol sometimes very easy to get the patient.
Yes.
Are we good with questions? Yes? Yes, so here I have the Dr. Ming, the inventor of the this product we're discussing about, and he will be at the booth at Tuoren answering questions as well. If anybody has further questions or wants to see the product or try it out over there, they'll be here during the whole meeting. Yes?
Thank you. Thank you for coming. Yeah.